An ocular oncologist has to be a pantograph in terms of all the treatment modalities one has to offer. In cases where tumor is surgically inapproachable, chemotherapy and radiotherapy play a vital role. Radiotherapy specifically has revolutionized over the past few years with improved outcomes and better safety profiles. In this video, we will be focusing upon basics of radiotherapy, various modalities delivering it, technique of delivery, surgical procedure, indications, and complications related to radiotherapy in the field of ocular oncology. Radiotherapy is a therapeutic strategy that impacts the DNA and interferes with replicability of cancer cells by use of radiation in the form of high-energy particles or waves. Electromagnetic radiation can be in the form of X-rays or gamma rays. X-rays are basically accelerated electrons, whereas gamma rays are emitted by radioactive isotopes. Particulate radiation includes electrons, protons, neutrons, alpha particles, negative mesons, heavy charged ions and beta rays emitted by radioactive isotopes. Radiation can be delivered to the target tissue in two forms: teletherapy or brachytherapy. Teletherapy is when it is delivered from far, and brachytherapy is when it is delivered from a close contact with the target tissue. External beam radiotherapy or EBRT or teletherapy has evolved significantly over the last few years, starting from 2D EBRT, 3D conformal EBRT, intensity modulated RT or IMRT, wherein each field is subdivided into numerous beamlets whose intensities are individually modulated to achieve a non-uniform dose distribution from each field. In rapid arc modification of IMRT, dose painting is achieved with opening and closing of multi-leaf collimators. Image-guided RT or IGRT workflow includes preparing a face mask from a thermoplastic tissue equivalent material. This is to manifest the superpower of our patients. Positioning with mask and infrared positioning. Verification with X-ray CT scan for the anatomical matching of tumor. Correction with 6D robotic couch. Snap verification at every couch angle. And finally, the treatment delivery. Tomotherapy works on the principle of IMRT and delivers radiation by rotating around the body, aiming target beams at tumors from many angles. The various indications of EBRT include lymphoma, wherein an ultra-low dose boom radiotherapy can be effective, adenoid cystic carcinoma of the lacrimal gland, orbital retinoblastoma, orbital rhabdomyosarcoma, fibromyxoid sarcoma, solitary fibrous tumor, primitive neuroectodermal tumor of the orbit, or Ewing sarcoma of orbit. Proton beam therapy is a newer advance which delivers higher lethal dose to the tumor with minimal damage to surrounding healthy tissue. Stereotactic radiosurgery works on the principle of stereotactically guided conformal irradiation of a target in a single session up to 5 fractions using X-knife, cyber-knife, gamma knife, tomo knife for ultra precision. The indications of stereotactic radiation include surgically inaccessible tumors such as cavernous hemangioma, optic nerve glioma, orbital apex meningioma, orbital apex schwannoma, or choroidal metastasis. Brachytherapy. With brachytherapy, the biggest advantage is that the required dose is directly prescribed to the apex of tumor with minimizing the damage to surrounding healthy tissue. These are of two types: plaque brachytherapy, that is for surface application, or interstitial brachytherapy. The indications of plaque brachytherapy include uveal melanoma, retinoblastoma, choroidal hemangioma, choroidal metastasis, and ocular surface tumors including ocular surface squamous cell neoplasia, lymphoma, and melanoma. The various sources of plaque brachytherapy are iodine, ruthenium, cesium, iridium, and palladium. On comparing the two plaques, that is iodine and ruthenium, we observed that the half-life of ruthenium is 373.6 days, which is way higher than that of iodine. Iodine protection is required and it demands recurrent maintenance. Plaques can be of different shapes, notch and round plaque. Notch plaque is when it is used for tumors near the optic nerve where the notch has to surround around the optic nerve, whereas round plaque can be used for surface tumors. As per the quadrant and size of the tumor, the plaque position is decided. For posterior placement of plaques, conjunctival peritomy is performed, recti muscles are hooked and tagged for the appropriate traction. The quadrant of plaque placement is exposed and scleral marking is done from the limbus. By suture, the spatulated needle is passed through partial thickness of the sclera, avoiding any sort of scleral perforation. The suture is now passed through the plaque islets and tied. Position of the plaque is confirmed and conjunctival sutures are taken for closing the peritomy. Plaque removal is done as per the pre-decided dosimetry timings by the radiation oncologist. Interstitial brachytherapy. In this procedure, after debulking or excising the tumor, hollow tubes are inserted in a particular pattern and very well distanced from each other into the residual tumor bed. Closure is then done with tubes in situ. As per the radiation planning, at the time of delivery of radiation, the radioactive source travels through the hollow tubes and delivers radiation directly to the tumor bed. Radiation is delivered in multiple fractions with each fraction at least 6 hours apart. The interstitial implant is later removed after delivery of all fractions of radiation. The indications for interstitial brachytherapy include adenoid cystic carcinoma of the lacrimal gland, orbital retinoblastoma, and so on. There can be some complications of radiotherapy and they must be kept in mind, like loss of eyelashes, thinning of eyelids, periocular pigmentation, which is reversible, dry eyes. However, the incidence of dry eyes can be reduced by proper shielding of lacrimal glands and managing with generous use of lubricating eye drops, keratitis, which usually happens on higher dose usage of more than 50 to 60 gray, and it can be prevented by eye shielding, cataract, which can be prevented by projecting the beams away from the lens, and if at all it happens, it can be managed with safety-enhanced cataract surgery with intraocular lens implantation. Radiation retinopathy, which can be managed with intravitreal anti-VEGF injections at regular intervals. Central retinal artery occlusion, although extremely rare, it can occur. A superlative evolution in the field of radiotherapy has enabled ocular oncologists to plan an implicit management protocol for surgically inaccessible or recurrent cases in a more structured manner, ultimately benefiting the patient in terms of improved rates of life salvage, eye salvage, and vision salvage.